excellent, because that is an important piece of this. Something I'll share is that this will be recorded and sent out to the registrants after this is over. I keep looking up here, but I think the camera's here. Okay. I already mentioned we'll take questions throughout, and I will moderate. So if you have any questions, so please put them in the chat. At the end, we will have time, hopefully, for a final Q&A. So any questions you have that we don't get to throughout the presentation, we hope to address at the end. And I'll ask that if you are not speaking, if you can keep your phone on mute so that we don't hear any background noise. And finally, if you have any ideas for future Ask the Expert topics, please let us know. All right. Oh, can you put the slides now? Thank you. Right. All right. So I already gave a little bit about myself, and you see my superpower. It feels generous to call it a superpower, but yeah, it's true. Help people make satisfying and fulfilling life changes through coaching and career development. We also have Shana Gage here, a triple board certified psychiatrist, nice, specializing in the treatment of child, adolescent, adult, and addiction disorders. Wow. She received her undergraduate training from Oakwood University and her medical degree from Howard University College of Medicine. Completed her internship and residency training at Howard University Hospital. And you had a specialty fellowship in child and adolescent and addiction psychiatry. Wow. Were completed at University of Maryland School of Medicine, where you were also chosen as chief fellow and served as an assistant professor. So we have some pretty impressive folks here today. It's got me stuttering trying to read the introduction. And also we have Dr. Shanda Priest. Did I say Dr. Shana Gage first? I want to make sure I got that in there. I mean, it's cool to be around so many Black doctors. There's not a whole lot of them. So, I mean, I appreciate being in the same space. Yeah. Dr. Shanda Priest is a board certified adult psychiatrist with fellowship training in integrative psychiatry. I think I want to hear about what that actually means, the integrative piece. Dr. Priest earned her undergraduate degree from North Carolina State University in Raleigh, North Carolina. Went on to earn a medical degree and completed her psychiatry residency. Okay, at GW, George Washington University School of Medicine in Washington, D.C. Following that residency, Dr. Priest served as an active duty psychiatrist in the U.S. Air Force. Thank you for your service, where she served active duty service members and their families and was deployed to Afghanistan for 6 months in support of Operation Enduring Freedom. After her military service, Dr. Priest has worked in several medical settings, including community-based, traditional outpatient care, and as a consultant for intensive outpatient programs. Thank you both for being here and being a part of this discussion today. Ooh. All right, I think we're ready for the next slide. So we thought we'd break this down a couple of ways. We could look at the historical context, of course, look at where we are right now in the landscape, and focus on what's coming up in the future. I think if I can, I want to start with a question to kind of get it going. Given our title of the shifting landscape of mental health, I'm curious from our experts on the panel, what is the shift that's happening, and maybe from where is it shifting and where do you see it going?
Well, I'll start, and thank you for the introduction. Yeah. And thank you, Bruce, for deciding at this beautiful stage in your life to become a therapist, because you are also well needed. I would say the shift is in kind of being more transparent about mental health in the Black community, being more aware of the mental health issues that face Black populations, and also in terms of treatment, training culturally competent treatment providers who are able to recognize certain symptoms that show up in a different way than they do in other populations. My experience is that many Black patients, when they walk into certain places, there is an altered perception of what they are facing. There are things that they tell you, and then the things that are unsaid. And I think that complicates the picture in many ways. And so I think the shift is, first of all, the awareness that we are trying to bring to this, and just being more open about this conversation so that we can decrease a lot of the stigma in Black communities about mental health and mental health treatment. But also, again, for me, it always goes back to allowing more people into our field who can actually help and be of service to our populations.
Thank you.
Thank you. And thank you again for that introduction. Yeah. I totally agree with Shana. And to add to that, it's interesting. When you mentioned the military, that made me think back to when I was deployed to Afghanistan, and about the third month in a group, I was there for 6 months. I was in the Air Force. So most rotations are about 4 months where they were for the Air Force. But with mental health, I was for 6 months. So we were there longer. So when I arrived, my first 2 months were the tail end of the previous, I guess, medical group's 2 months. So I really didn't meet too many people. I kind of felt somewhat isolated. I mean, I met a few people that I was working with. But then that next 4-month crew, I will say, rolled in. And I met about 4 or 5 of some lifetime friends. They were all Black officers. It was 4 other females and 1 male, and they became like my family. And one of my good friends, Lila, who I met at the time, she is from Texas. And I remember her asking, like, what do you do here? And I told her, oh, I'm here, for mental health to serve. And she was like, what? And it was so funny. She's from New York, and she said, Black people don't go to the doctor. And so I laughed, and I was like, Lila, haven't you heard? Black people are the doctors. And it was like a joke, it was like an internal joke, but it was really a moment of like, oh, wow. And so even within that small group, they weren't even aware of what mental health was, and just kind of exposing, yeah, this is us, this is every day, putting words to what that experience is, and realizing, oh yeah, I've kind of been going through that. I didn't realize that was is something that I could get help with or open up about. And what's even better, my same friend Layla, she ended up retiring, and she went back to school and now is a social worker and works as a therapist for our veterans. So I'm not even sure if I answered the question, but just kind of.
Yeah. I mean, it makes me think about the historical context. And I actually have 2 questions here, or we could go in 2 different directions. One is, when and why did mental health get separated out from, I guess, health overall? Because I wonder if that contributes to some of the stigma that it feels other than. Maybe we can start there. When and why did that happen? I know it's kind of a big question, but any sense?
I'm not sure when. As long as I've known and learned about mental health, it's been this separate entity, and I certainly take issue with that. But even in training, it's you have, here are your medical courses, and then here are your psychiatry courses, and depending on who you are, that's the part of training most people don't look forward to.
Correct.
They don't want to be a part of the mental health, having to go to psych wards and things. But I think a part of that may be, again, if you think back to mental health for Black people, it probably goes back further than slavery. But the mental health aspects of slavery and what took place were not recognized for a long time. We certainly can see on documentaries and films the physical aspects of what took place. But many people don't talk about the mental health side of things. And of course, without talking about it, you're less likely to open up about it. You don't feel validated, and you're less likely to seek out any sort of care. And so I don't know that I can answer when that happened, but it's been going on a very long time. And again, I think a part of our conversation is try to make sure that we combine that and people understand mental health disorders are medical conditions that require medical treatment along with the other supports that are in place for it. So I'm happy we're even talking about it.
And I will add to that, like, I feel like my whole life is a lot of stories, but to add to that, Shana is absolutely right. I remember starting medical school. I'm excited, initially saying, oh, I'm going to be a pediatrician. That's what I thought I was going to be. And then, so medical school, your first 2 years are clinical, where it's basically classroom, and then you start rotations, which is the clinical piece. And we have I think it's like 6 core rotations, and maybe different nowadays, of the standard rotations that everyone has to go through. And each one at GW was 2 months. 1 month is inpatient, and 1 month is ideally outpatient, like an outpatient clinic. And when I did my pediatric rotation, it was like, oh, this is nice, but it really didn't fit me. So then I was like, oh, I want to be an OB doctor. I want to do that life. And then I did that rotation, and then I just really didn't like surgery, or there's a lot of aspects. And so with each rotation, I got towards the end, like, I don't think I really want to do any of this. Surgery, I couldn't stand it. You had to be there super early, and it was just not for me. It's for a lot of people. But it wasn't for me. And so my last rotation on purpose was psychiatry, because I was like, I don't even know what that is. Are they even real doctors? I'm not going to do that anyway. And I was getting married at the time, and I wanted to take a week off to go on my honeymoon. So I was like, that's the least desired rotation anyway. Boom, it works for me. So anyway, I get to this rotation, and the first month is absolute it was exactly what I expected. Like, who does this? This is bizarre. Where I was a very, very high acuity, severe inpatient place, and I didn't know what was going on. But that second month, it was like a storm hit. And then the next day, when the sun comes out and the sky is clear and blue, it was my consultation liaison, where I had the opportunity to work on a medical ward for people who are admitted for surgery, medical problems, anything. And you do a consultation. So you get to go in and sit down and talk with them and ask about their lives, because the service requested you come and see them oftentimes for depression or anxiety, or they're not participating in treatment and they need help figuring it all out. And so I realized at that point, through every single rotation, that is what I loved the most about each one, getting to know my patients, asking questions. I remember my surgery rotation, I almost got in trouble on rounds, because I would present, this is a 26-year-old so-and-so. She has twins. And I was on this huge social history, and they were looking at me like, who cares? Like, get to why she's here on our service so we can treat her and, get things moving. And so, but to your point, I don't know why it's spliced up, because it's so integral in every part of medicine. If you're not feeling well, if you're on edge, if you're sad about a diagnosis, if you're nervous about what the doctor's going to say, like the way you interpret and even engage in health and treatment is not optimal. And so I feel like it's like somehow been the background, but it's like the cohesive piece of medicine, right?
And mental health disorders are closely associated with many of the major illnesses, right? So heart disease, strokes, cancers, we know that depression is typically a part of that. And so when you have people present with, these really kind of life-changing illnesses, you really do a disservice to not assess for the mental health aspect of it, because we know that they are co-occurring many, many, many times.
We have some comments here I want to get to in a second, but I still feel when I hear disorder, I think there's something about, even if it's, diagnosed properly and there's a treatment for it, there's something about feeling as though something in me that I didn't have control over is broken. And I think admitting like to someone else that you don't know, especially if they're not the same race, and you're like, you're coming in already feeling deficient. And I'm wondering if you have advice for patients who are in that space of I'm admitting something is wrong about me that I don't feel like I caused anything, but also for the clinician as they are working with people who are coming in with that frame of mind, like how do we get both parties to get over that initial hump?
And I will start with that. That is a wonderful question, and I absolutely love it. I work with a lot of people, all ages, all stages, but especially with a lot of college students that I work with. And the best way I put it is I always start with I, or we, when we feel this way, when we are thinking this way, when we're feeling, or etc. And I always say we all, because it's true, we all have air quotes symptoms of almost any and every, mental health condition, whether it's anxiety or feeling sad and down or a crying spell. All of us as humans experience these symptoms. That is normal. That is part of life. We're supposed to react and respond. We're supposed to have emotions or feel sad or feel upset or angry when things happen. The change, or it becomes a disorder, is when more often than not, we're feeling those things and we're not connecting with our partner. We're not wanting to be around our kids. We're not wanting to go to work, or we're going, but we're barely there. That's a disordered way of living, So if you don't look at yourself as a disorder, but the impact of these things on you are taking away from your life in some major way, then that's when we call it that. And the other big thing I always point out is, please don't get frustrated or caught up with a diagnosis. That is a way from a clinician, or even with our patients, for us to communicate a collection of things. And I love to tell my students, like I'll say, you know what, when they start to get nervous about that, I will say, you know what, if I hadn't spoken to you and your therapist sent me, a referral and said, oh, I think this person has generalized anxiety disorder, I will say, without meeting you, I may not know the details, but I will bet more often than not, you're like super worried. You're on edge. When you try to go to sleep at night, your thoughts attack you. You probably feel some tension sometimes your heart, and you're like, oh my God, how did you know that? And I'm like, because all it is a collection. It's a way to simplify things, to communicate. It's not meant to mean anything beyond that.
So the way that I approach it is I try as best I can to turn it into a medical condition. That is what it is. But for them, they don't see it that way. So what you just talked about is this sense that I have a weakness.
Yeah.
There's a personal thing about me that's not right. And, it is not uncomfortable. It's not comfortable for me to walk into someone's office and say that. And so I usually, when I'm talking to, let's say, children's parents who have ADHD, right? I'll say, listen, so if your child was straining to see, if they couldn't see and they told you, Mom, I'm getting headaches, I'm having a squint, and getting dizzy, would you call that their personal weakness? Or will you say, well, something's wrong with your eyes, let's go find out what it is, right? And so when you turn these disorders into what they truly are, which is medical conditions. So I usually start with talking about the brain, and the brain being the control center of the body. And if your brain is an organ in your body, just like your heart and your lungs and your kidneys, then shouldn't we be okay that the brain sometimes doesn't feel well? Sometimes it is subject to dysfunction, and there are many things that cause that, just like with other disorders, just like with other medical conditions. That can be genetics, that can be our environment, that can be our current situation, stressors that we have going on, that can be other medications that we're taking, substances that we're using, alcohol that we're drinking, right? And so it is the same thing, except there's no brain cuff to put on it. So that's where the, the abstract part comes in. Because like, how do you know I'm depressed? How do you know that's what that is? Can't put a brain cuff and it reads depression or it reads anxiety. But it goes back to what she said. When you see a cluster of symptoms, this is the diagnosis. Many people experience this. That also then allows them to see, number one, they're not alone. Number two, this is something you've heard before. So hopefully they have some confidence that you know how to help them. But overall, when you compare it to other medical conditions, I think it kind of takes away that feeling of I did something wrong. I say, did you cause your eyes not to work, or did you cause for your lungs to not work and you have an asthma attack? Okay, so you didn't cause your brain to go through some imbalances that are causing these emotional symptoms.
And I'd love to piggyback on that, especially with the topic of what we're talking about in BIPOC communities, which often, or I should say not infrequently, comes up. Depending on the age and stage, it could be a younger person who is open to mental health, but they hear medication and they're like, I don't know. Or they're like, yeah, I want to do it. But their parents are like, I don't know about that. And then it becomes, well, my mom or my dad are really concerned. And, what often comes up, let's pray about that.
Yes.
Let's pray about that, and which I welcome. Prayer is a part of treatment.
Yeah.
However, as Dr. Gage just said, I would say, wow, does anyone in your family have asthma? Okay. Do they have diabetes? Grandma? Okay. How about we ask them not to take their medication and let's pray about that? Like, that's unheard of. Why? Because we accept there's medical treatment for that. So the medical model is awesome. It's an awesome way to illustrate that, because there's medical treatment for this too. It's so different. So
I think hearing you all explain it certainly makes me feel better. And then I thought, well, we need to get the word out on this to other folks, which is what we are doing here. But not everyone gets to talk to a clinician who knows how to explain it that way. So thank you. We got a couple comments, and then I have some questions. Let's go back to Adrienne. Thank you for your comment. She points out that get that? Or Adrienne pointed out that we've only recently begun to discuss intergenerational trauma, to your point earlier, and acknowledge that many of the medical issues that people from the diaspora, and particularly African Americans, are at increased risks for, in part tied to systemic inequalities, bias, and racism. And you said a lot. Trauma and adverse events have a tremendous impact on our physical and mental well-being. Yeah. Got a couple co-signers on that. And Dr. Brown also approaches it as a brain as being an organ. So yeah. One more comment from Adrienne. As a pediatrician, I stress that if the brain and mental health are not taken care for and treated appropriately, their physical health and other aspects of their lives will be negatively impacted. Relationships, work, school, sleep, etc. Okay. Let me go. Oh, that got away from the deck here. We started with historical context. Had one more piece in mind I thought about as I was preparing for this. I thought about the Tuskegee experiment, where there were cases where these Black men had untreated syphilis. They did not realize this, though, until this experiment was over. During this time, they thought they were being treated. And when the conversation of our Blacks and people of color's relationship with the medical community comes up, this topic of, well, there was a Tuskegee experiment, and like look at how unethical that was. That didn't end that long ago. I think that was over 1972. So you're like, maybe that's 1 or 2 generations ago. Are we in a safer place now? I mean, is it still do we still need to be, as clients, uh, concerned about that? And do you think that plays into some of the hesitance of people of color to seek out the appropriate medical treatments for their conditions?
Absolutely. But like you said, intergenerational, right? So these stories get passed down. And so I will say, and Dr. Priest said it before, we have a new generation who are a lot more open to coming in and talking about, probably more so because of social media, right? Everyone is bipolar, ADHD because of things they see on social media. And I'm okay with that because even if you're not, I'm happy that you're willing to come and talk about it. But I want to give you a specific example. Just this week, I saw an 58 or 59-year-old male who was sent to me for a trauma situation. He is a bus driver and he was assaulted on the bus. And he came in to talk about this, and he said to me in the beginning of the evaluation, "I hope you don't mind, but it's really hard for me to look at you." And I was like, "Well, why is that? Something wrong with your video?" Like trying to figure, and he's like, "I don't feel good talking about this to you." He was like, "I'm really embarrassed." So I was like, "Okay, well, like, help me understand. Why are you embarrassed? Something terrible happened to you." And he's like, "Because I'm a tough guy. I don't go to the doctor. I don't have any issues that I feel like I need to talk about with people. I've been through a lot of things in my life and I've never had to talk to anybody. So coming to you for this just feels very, very difficult for me." So this was so heartbreaking because when I talked more, I heard about the trauma itself, but when I talked more with him, throughout his life, he's gone through multiple deaths, of course, like many people have. One this trauma, something you think should not be a big deal, all the other things that you think you kind of tucked away somewhere, they're all coming out. And
that's scary.
That is scary. That is scary. The fact that he said, "I've never even thought about going to talk to somebody about any of this." What he did say was he goes to church and he even goes to a men's group. And I thought that was great, but I said, "Do you bring this up there?" And he said, "No." So even in the setting where we would hope that you could get some support, he didn't feel comfortable bringing those things up. The other thing I want to say is that when we started to talk about things that could be helpful, including medication to help for his trauma response, he said to me, "Well, I don't want nobody experimenting with me."
Oh.
So to go back to your question. And so he has not been to doctors. He has not really taken medications, though he may need it. He did tell me he thinks he's pre-diabetic, but he never followed up because the doctor said, "If you don't get your blood sugars down, we may have to go on medicine. So I'll fix it. I'm not going back if you're going to give me medicine." And that was the first thing he said. "I don't want anybody experimenting with me." So that answers your question, I think, right?
Yeah.
This is the thought. And it took a lot. And again, I think you have to know how to approach patients who have this thought process. They have to feel like they can trust you. They have to feel like what you are doing is in their best interest because there's a part of their brain that says, this person may be out to hurt me. And that certainly provides a challenge for us as their treating providers. But again, the reason why it is so important that we have people who are trained and who understand the traumas in this community and know how to address it. I couldn't go in there and say, well, you have PTSD, you need medicine. Anything else?
Right.
I had to be willing to hear the traumas, let him know the process of how trauma causes these reactions for him, and also get him to trust me to consider taking something to help him. And that is not an easy task.
No.
And again, I think that is where that intersection of, like you're saying, having competent, people who look like you. There's a certain level of, like an unspoken level of just,
yeah,
where it's not automatic. It kind of is, and it kind of isn't. Like the initial potential barrier to trust, it comes down a bit. I would say, and that is one thing I have loved working with in this area, especially, working with other African Americans, men and women, different ages. Is like there's just an initial, like, I see you. It's I don't even know how to it just adds a level of comfort, and then ideally trust, especially when you have someone who's actually want to listen to you, let you finish your sentence, not minimize what you're saying. Listen, I don't mind at all when someone is a little guarded or they come in like, what I'm not going to do is, what I'm not going to do is take this or take that or start that. And I'm like, that, I can like have a little fun with it. Yeah. And I'm like, well, I hear what you're not going to do. I hear it. And then just to be able to say, well, can I just share something with you? Ask permission. Okay. What I'm hearing you say is this, reflect back what I'm thinking I'm hearing and say, well, these are the things, I've been doing this for a while. These are the things I think could be helpful. You don't have to do it. I trust you. I'm listening to you. You're with yourself every day. We're meeting today and I want to continue meeting with you. But I'm here to work with you. Where are you willing to start? And it's some people who have seen other providers or you get a history of prior medications and like, oh, well, tell me what happened with that. Oh, I took it one time. I'm like, well, why'd you stop? And they'll mention like some random innocuous and a side effect. And I'm like, follow-up. Like, yeah, did you go back? Did you let your provider? No, I just didn't. And I'm like, wow. And so I try to emphasize using a lot of my time doing education about what I think it is, diagnosis, and we want to, put a name on it, putting a name on it, and also really explaining if we're starting medication, why I think it's helpful, and the best way I can explain it to how it will work to help you. Because most people are like, oh my God, no one ever told me that. Mm-hmm. That makes complete sense, versus just take this pill and come back and see me in a month. That can be very scary, if not terrifying. Versus if I tell you, let's start low. At first, you may experience this or that. It's going to go away. If it doesn't, call me. But I really think you'll be okay.
And what I want to add, I don't want to make a blanket statement that, Black people should just see Black people, because I don't believe that. I don't believe that. I do think, though, it is important that all people who are trained in the medical profession are aware of their implicit biases and that they do things to address them if they want to treat all populations. And so I always talk about my training at University of Maryland, which is in the heart of Baltimore. And I trained with Caucasians and Chinese and different cultures. But I can tell you that they got it. The training that they had in that setting, prepared them for probably wherever they may go to work. And so I don't want, the message to be that if you walk in and it's not a Black doctor, like, you shouldn't trust. But I think that as clinicians, we should all kind of take pride in knowing our biases, whether we think we have them or not, being open to the fact that we have biases and doing something to address them, so that when any patient walks into your office, you feel like, even if you don't understand them, their culture, their religion, whatever it is, that you know how to approach them and learn more about them, be willing to understand the things about them that make their treatment difficult or makes it hard for them to have a diagnosis or makes it hard for them to take medication, and that you don't just kind of insert, what should be our recommendations so that they feel like they're being forced to do anything.
Yeah. Thank you for bringing that up, because as you were talking, I was thinking, well, these seem like skills that every doctor should have. And we shouldn't. I should be able to get this anywhere I go. But can we go to the next slide, please? I think I have another question here. Hang on, I wrote some of these out from the very beginning. I want to always like to balance out my questions on the heavier, more serious topics, which are important to talk about, with a lens toward the future. And I want to get you briefly touched on this a second ago. I'm on Instagram probably a lot more than I should be in a room with doctors. But what I've noticed is a lot more content creators of all colors creating videos and different skits that have to do with mental health. I think a common one is ADHD. Like, I went to empty the dishwasher and then I realized, there were already dishes in the sink. Somehow I ended up at True Value buying a screwdriver, like that, those sorts of videos. And so I would like to get your thoughts on, where do you see that in this? I'm thinking it's helping the space. It's certainly giving us the language to talk about it. But on one end, I hear a lot more, also to a point you made earlier, like trauma. There's a lot more of like narcissism and these terms that I thought had a certain kind of clinical weight. And now it's like, oh no, this boss is toxic.
Right.
Or
Triggered.
Like my mom, yeah.
That triggered me.
Yeah, so I'm trying to figure out, like, well, where's the sweet spot? And is that helping or hurting you with your work?
It's an opportunity. I will say that. Like Dr. Gage said earlier, I'm happier that they're here coming in, starting off saying, my bipolar this morning was really acting up. And then, I have BPD, which I always have to say, which one are we talking about? Borderline personality or bipolar? Like, I love it. And I love when someone comes in, well, my this, my that, or my ADHD. And I'm like, okay, I'm here for it. So I'm listening, taking it all in. And then I'm like, pause, like, can you just tell me what you mean by that? Because I just say the same diagnosis can apply to different people, and no two of them are the same. Mm-hmm. So help me understand day to day, what does that look like for you? And then, tell me what's happening. And then I love when doing an assessment, and when I'm assessing for mania or hypomania, they're like, I've never had that before. Like, what are you talking about? And I was like, what's your bipolar, right? Your bipolar this morning? And they're like, no, that's actually not bipolar. It's and kind of explaining what it is and what it isn't. And it's beautiful. Like, I love, educating, and so someone will have a better idea of how to then, emote what they're going through.
And I would say, yes, I mean, there's certainly overuse and misuse of some of these terms, right? But again, I prefer us having the conversation and the opportunity to provide the proper education. Right. And, like you said, these are trends, but they are bringing awareness to it. And so I'd rather go through, like she said, these symptoms with you and, kind of ding, ding at the end. Guess what? You're not bipolar. How amazing is that? But I really do appreciate that this time has allowed for, kids, teens to see things that they relate to. And even if their parents were not open to it or did not recognize it, they may take it to their parents, say, Mom, I think I have ADHD. Like, look at this skit. Isn't that me? And then they say, actually, yeah, you do those things. of course, the problem is for the parents who say, yeah, you have that, but you're not going to see any doctors about that, right? We're just not doing that. But I think it opens up the conversation in homes. It gives kids a way to really kind of show this is what I think I have when they don't know how to express it themselves. And again, just having the awareness of it, I think gives us a better opportunity to be of service to our communities.
Thank you. I think I want to dig a little deeper. Can we go to the next slide? We are a center that focuses on ADHD after all. And last week we had a panel that you were part of where we talked about the rates of misdiagnosis, or really the underdiagnosis within specifically the Black communities. And we talked about how it could show up, it being ADHD could show up differently or I'll give an example of young Black boys can often be seen as having behavioral disorders, but beneath it is actually the inattentive or impulsivity issue. Can you share some highlights from that last panel we did about the consequences of this underdiagnosis, specifically with ADHD and what that means?
Yeah. Well, I think the greatest consequence, especially for our young Black and brown males, is what we call like the school to prison pipeline. So where, symptoms are kind of dismissed, ignored, or again, misdiagnosed. And instead of getting, accurate assessments and treatment, again, they turn into behavioral issues. And so I think any teacher, when you think about a kid in your class who has a diagnosis of ADHD versus a kid in your class who you just think is disrespectful, doesn't follow the rules, doesn't want to do his work, your approach is different, right? So a teacher sees a kid and they know they have ADHD diagnosed and it's in their paperwork. They say, hey, that's why Johnny's not paying attention. He maybe didn't take his medicine today. So they have a different approach. But if Johnny does not have that diagnosis, and this is, continuous, consistent pattern that he has, and no matter what I do, whatever modifications or things I've done to help him, it goes on. I now think he's being defiant. He does not want to be better. And my approach comes from a place of resentment, irritability, anger. I tell kids all the time, like, teachers are human beings. So when a teacher does something inappropriate, like, we certainly would like them to have proper boundaries, but they are still human beings. And when you push a human being to their limit, it's hard for them to control it sometimes, right? And so we hear a lot of stories now about, we see it on the news, children attacking teachers and different things come up. Was it autism? Was it ADHD? Or was this just a kid who doesn't care and is a criminal? And I would love if we were able, again, to have a society where children had the available resources, could be accurately diagnosed and treated. And then I wonder how many of these stories we would still have to see on the news.
Right.
Yeah, I can see the teacher being like, well, if you don't care, I don't care.
That's it.
I've been trying to work with you.
Yeah.
I mean, teachers have a pretty challenging job, I think, already. If you got a classroom full of 20 young adults or more.
30.
And everyone learns at least a little bit differently and processes a little bit differently. I mean, it's not necessarily a question for you to answer, but I'm like, what's even a reasonable expectation we should have of a teacher to be able to
manage it?
Yeah.
That's a great question. And I'm not a teacher. I'm trained as one. I really couldn't answer that. But kind of speaking to what Dr. Gage mentioned, I think the approach, is the biggest piece of it, right? Because one approach could be disciplinary. You need to go see the vice principal. This needs to escalate, which that may indeed need to happen depending on what's happening in the classroom. as opposed to, or a comma, I really need to reach out to your mom and dad. I really need to see what's going on. Are you getting your medication? Or is there anything else that's going on? Just having that space, if you know that a kid has diagnosis, or, you just have a different level of space or tolerance for certain behaviors, because it kind of makes sense versus just looking at the behavior itself and not the student as a whole. Which I get if they're like, obnoxious or class clowns, or they keep interrupting, classic symptoms of the hyperactive piece of ADHD. It's hard not to focus on that blatant stuff. But if you have an awareness, again, there may just be more of a capacity, like, some of this is out of that person's control. What else can we do? What else can I do?
I think back, I'll share my own experience in school. I mean, looking back on it, in my house and in a lot of houses around me, I grew up in public housing, the idea of mental health, seeing a doctor, having a diagnosis, it was very much, this is a white people's thing. We don't, or this is a money thing. So like, you're going to have to figure it out. And I remember sitting on my hands in class because and I think from the teacher's perspective, it was Bruce is being disruptive. He's being a class clown. I'm not even an extrovert. I was just bored. Like, the work was done, and
What else?
yeah. And the response was, "Hey, come get your son. He's cutting up in class." Thankfully, I mean, I eventually got teachers that were better, and let's say they're bad teachers, but they were kept me more engaged. The lessons were more interesting. The skits and acting out that we did in class made it a lot more fun. Yeah. And I look back on that now and I'm like, wow, how many I changed classes right around third grade. And that's when I noticed we started to have what we identified as like, oh, this is the smart group. Mm-hmm. This is the, behaviorally challenged or learning disabled group.
The bad class.
Yeah. and we all grew up together. And like, I'm like, well, this feels weird to me. We're all like getting the same high school diploma now, but we've all had very different experiences depending on how we were labeled when we were like 8. Yeah. So.
And the unfortunate part about that, Bruce, is that you have a lot of children with ADHD who are put in classes with children who have really serious learning disabilities. And many people with ADHD are brilliant. And so in many ways, they are having a disservice because they're not challenged in these classes. These are the classes that are meant for people who actually need a slower pace and individualized attention. And if they'd had the right diagnosis, they could probably be in the accelerated class. They could probably graduate early. I mean, there's so many people, young men and women with ADHD, who are geniuses. But like I tell parents, nobody knows that. Nobody knows. Or they do know, and so they don't understand why you're not doing well, right? They can say, well, you get the grade, like you get A's on your test, but you don't do your homework, or you disrupt the class. And the teacher is actually like baffled. They're like, how do you get 100 on your test? Because you're actually a brilliant kid, but your behavior, because of the disorder, does not allow you to show up as your best self all the time. And so, if you think there are many like just brilliant people in the world today who will look back, doctors, lawyers, judges, all kinds of professions, who will be like, yeah, I had ADHD as a kid, took Ritalin, didn't like it, or my mom didn't like how it felt, or my mom would not let me take it. And, who knows how I got here, but because you were a genius back then, but nobody assessed or diagnosed or gave you the proper treatment.
And I thought about that word being labeled, because I do remember talking with the patient themselves. They were my patient. I see adults, but they had a child with ADHD, and maybe I'm blending people together, but I do is the issue of like, I don't want my child to be labeled. And so I love Yes, tell me about these labeled paranoias or fears, because I try to like just like with CBT, like the way we look at something is how we will respond to it. So I wonder if we could flip that label or that diagnosis into a good thing. We can call it something. The fact that your son or daughter can't sit down, or they're always losing their homework or always losing their keys that are right inside their pocket. Why do we got add a label to that? That gives us options.
Yeah.
That gives us an IEP. That gives us accommodations. We can actually have your child take their exam in a place where it's more quiet. There aren't more noises around that take away their attention in the moment. This label is a good thing. And I'm thinking about one of my patients who's a physician who was diagnosed with adult ADHD, and she has a son. That's how a lot of adults come in after their children are diagnosed. Yeah. And her son is 8 or 9, and her son, you know, she has 2 boys, and her oldest is her world. And, you know, she's a radiologist. She's like, whoa. She's like got to become where she is now, but when she looks at her child who was always getting in trouble, not doing her homework, just always just this movement, but very bright, can do her job, like, because it's rote now, like every day is like yesterday. However, outside of that, you know, getting the kids together in the morning, getting them ready, you know, always leaving behind a book or a lunchbox or something. All of these pieces that all are always falling apart are now finally coming together now that she has treatment. And it was beautiful because her son even said to her, and I would love for our culture to take the same approach. He's like, I have ADHD. Like he says it with pride. My brain is different. You know, if we could change that feeling about that to something where it's like, I can call it what it is and I can do something about it. Because he feels empowered about being knowing what he has and what he can do to help himself. So.
You know, in this moment, and lots of moments in my studies, am conflicted because there's a part of me that thinks, wow, this is really cool that we could like frame this differently. But then there's a part of my brain that is just so deeply ingrained, like, like there's something's wrong. You should be able to figure this out.
But think about what that means, Bruce. Like this, you're in this profession, right? You have the information, you have the access, and you still feel that way, right? So just imagine if you don't have any of that, right? How will you ever get to that point where you feel comfortable? Which is why things like this are so important. Because again, that stigma runs deep. It runs through our veins. And, you know, I think even for me, I've been a psychiatrist for a while. I still have to explain to people in my family, like what depression, like they don't get it. They're just like, well, why? I mean, you do things to make yourself happy. What does that mean? And it doesn't matter. So you don't respect my profession and what I do, you know, but it's foreign to certain people that anything related to your emotions, your concentration, your feelings, that can be medical. And so we have to change that landscape. We have to shift things so that our communities are getting the appropriate care, treatment, and thriving the way that we really know that they can.
A deep breath. I want to read some comments that we got. We move toward the end of the session. Let's see. Josiah mentioned, I want everyone to be diagnosed properly, to get the care they need, and to get the educational services they are entitled to by law. But is there also room to see neurocognitive diversity as natural for human beings, and to hold society accountable for creating conditions that will allow divergent humans to thrive? So, you know, who did I hear this from? Did I hear this in the panel? Or was it, who was he for ADHD? We're a world that's designed for people with ADHD is a world that's better for everyone. Yeah. The accommodations or the way that you would do in the same way for someone who has a physical disability. I know a lot of the technologies that we have only came as a result of someone who had, impaired vision or hearing or mobility that now give us access to things that we use and kind of take for granted, but those were created because somebody needed them. So,
and our curbs and sidewalks. Time where they didn't go down like that. Wheelchairs couldn't readily, be independent. They needed help getting up and down off of curbs. Those types of things become for all of us. We may not think about it that way.
Another comment from Yesenia, thank you. People with higher level functioning autism, level 1, often face real challenges in social communication, especially during the teenage years within the school system, which can lead to added struggles like anxiety or depression. Unfortunately, these issues might be missed, especially in minority communities. And we have Laura sharing some personal experience. I am 56 years old and was diagnosed with ADHD a few months ago. Welcome to the family. It was overwhelming to get this diagnosis. Friend told me that she learned a lot about herself after she was diagnosed. So I decided to approach my diagnosis as an opportunity to learn about me. That's beautiful. That is why I'm here today. I'm learning about me in a way that I never imagined. I'm grateful for the diagnosis now. To your point about reframing and taking the label and turning it into something positive,
right?
You can see the diagnosis as, oh man, this is like something else I have to deal with. Or I know in my own experience, and it sounds like for you too, Laura, when I look at my life through the lens of ADHD, and I see so many other traits now, I think, oh my goodness. Like if I would have known, we could have done something about this a lot sooner. But I thought this was just me not being able to behave. Yeah.
I think there are some people, and I love her comment about, just how she sees herself. It makes me think of a patient who I have who, she tells me like, because of her ADHD, she has like these billionaire ideas in her head. And I'm like, well, put them on paper. Like if you don't want to, give them to me. But she's just like, yeah, these things just kind of pop in. And I'm like, what if one of those things is actually a thing, right? But so it doesn't have to be all negative, right? And again, just that reframing and kind of figuring out where are these things appropriate for me and how can they benefit me? And then in those other places, knowing that I have some difficulty or struggle, I know there's something I need to address and how to address it, right? And so we are seeing more, I'm sure you will agree, like college students who are asking for accommodations. And I think it's a beautiful thing because these are students who would typically end up failing out of school, being socially isolated because of their ADHD and the symptoms. It's not just about education, it's about social life as well. And again, getting this diagnosis and being eligible for accommodations allows them to get their work done in a way that is doable for them, allows them to take these exams that they typically may fail or not do well on because they didn't have enough time, and to thrive and think about the level of confidence that comes with that. Like, I can do this thing and I am not deficient, Bruce. I am not challenged. Like, I learn in a different way, but there are things that we can do to help me to thrive just like everyone else.
And I will add, it just helps you to welcome yourself, like welcome your brain, and ideally take away some of the shame maybe or guilt of not getting everything done in a cookie cutter type of way if you look to your left or your right, but just acknowledging I have a lot going on, in my brain and just realizing, okay, brain, I'm doing it again. What can I get done? Or, for some people, they may need to time block or just, they use different strategies and just have more grace. Like, you know what? I didn't get a lot of stuff done today. That's okay. Tomorrow, I will try to organize things a little bit different, or figure out whatever they need to do. Everyone doesn't need the same treatment per se. Everyone may not necessarily need medication, but there may be some way to just organize your day in a way that works for an N of one, just for you. And so that's the whole goal.
And I want to go back to what she said, because it's important that, that feeling that you are not doing, that feeling of inadequacy, right? Like, why can't I?
Right.
That person can, but I just can't. Those are the seeds for depression and anxiety, which are commonly co-occurring disorders. Right. And many times that's how people show up. So we talked about this last week on the panel that, many times people will come with the depression that resulted from this, or the overwhelming anxiety. And really, ADHD was at the core of it. And so it's unfortunate, because you have some people getting to the point of being hopeless about life, because they're just like, I can't do it. Yeah. I don't meet up to the standard of other people, and I don't feel good about that. And so what's my purpose? Like, why am I here? And that is, heartbreaking for us, but also like, wow, we're so grateful you're here and we can intervene and help you understand more about yourself, that this is not you. It's not your personal weakness. That word that she used of grace. If you don't know what you have, then you don't know how to give yourself grace. You don't know. So having a name, having that label, again, not to make it an excuse for things, but it allows you to understand more of why certain things may be more difficult for you. And you don't have to feel shame, and you don't have to feel guilt, and you don't have to resent yourself because you're not measuring up to, again, what the young lady said, kind of normal societal standards of things.
We're almost at the end of our time here. And so what has become very clear to me is, as we talk about the shifting landscape, and I opened up with like, well, what's shifting about it? And I think what I'm hearing is the biggest shift is happening up here. It's a paradigm shift of being at the kind of individual's level to be open to the diagnosis not being a sign of defeat and causing demoralization, but something that creates opportunities for us if we can manage it. And also shifting the paradigm on how we view like the role of our physicians. I'm really impressed by both of you. I feel like a lot of the doctors that I've seen and the stories that I've heard, as a coach, I hear so much coaching in what you all do, like the reflecting back to the client what you're hearing, not forcing them to go in a specific route, helping to deep dive and figure out like, well, what do you really mean by this? Well, those are questions I ask on a daily basis. And so I think to have that skill paired with your training and background, like your patients must be really thriving. So thank you for that. And for those of you on the phone and who are watching and listening, thank you for all of your comments, sharing your personal stories. I'll turn it over. In a big conversation like this, where there's such a need and there are disparities and inequality, it can feel big and insurmountable. So I want to ask you a final question of what's a really small, manageable, doable step you could share with the community that helps us keep this shift moving in the right direction, like something easy that we can do today, or maybe we've already done today.
If you or someone you know is struggling with mental health, just start doing your research on it. Don't ignore it. Don't just expect it to go away. Don't just expect that God will fix it. Just start doing research and learning more. And I think the more information that people have, the more likely they are to take that next step. Okay, wow, I actually can resonate with all these things I just read. Maybe I should consider getting an assessment. So the biggest thing for me is ignorance, and not wanting to know. And so I would really challenge anyone out there who is struggling with any form of mental health concerns that they know this is not myself or my child or my parent or my sibling, whoever, to learn more about what you're experiencing or observing or feeling, and then see if that's something worth pursuing. The second thing, I'm just going to add one more, is like, do not be afraid to reach out for help, right? The help exists. We certainly can do a better job of making it accessible and affordable to everybody, but do not let things progress to the point that now it's more difficult for us to intervene and actually help, right? Because just like any other medical condition, if you came when you first had chest pain, the doctor could have prevented a heart attack. So what I tell patients, if you came when you first started feeling bad, we can prevent this brain emotional attack.
Yeah.
And so prevention in every other sense of the word in medicine is really the goal for every physician. It should be the same way in the mental health field.
Thank you.
You're welcome.
Wow, that's a lot to come after. Everything she said. I think when I think of the tiniest, smallest thing that someone could do, parallel or kind of similar to what Dr. Gage said, is think if you or your child or your best friend or anyone was wheezing out of control and they had asthma and they had an inhaler that they could use, what would you feel in that moment? Would you feel like, oh my gosh, please use this, like, please get some help? And I want you to give yourself that permission to see this as the same thing, the same level of importance. It is for you, it is definitely for you. It is completely okay, but just always just think of that analogy. If my child were, again, in here wheezing on the floor, what would I do? You would spring into action. And so that's what I want them to do, to think about that. This is actionable.
Well, thank you both.
Thank you.
Welcome. Thank you, Bruce, for hosting.
Yeah, and thank you all too. I think we'll go ahead and wrap up for today. Bye, everyone.
Bye, everybody.
Thank you, Julianne, for your help.